बच्चों को भेज रहा हूँ 5 पे।
Ready, sir.
Dear doctor, very good afternoon to you. Thank you very much for joining us. Welcome to DigiNeuro, a digital initiative by Health and You. Health and You Therapeutics is a joint venture with New Link Company Limited, Japan. Our mission is to fulfill unmet medical needs by launching innovative first time in India products. For example, Amnurite, the first amitriptyline plus mecobalamin combination for migraine, tension type of headache, and in diabetic neuropathy. You will see here Amnurite is also available in a small dose of 5 milligram. The 5 milligram dose was not available even with plain amitriptyline. So you can start with Amnurite 5, up titrate it to 10, and Amnurite 25. So this is our first innovative brand launched in the market, first time in India. We followed that up with Amnurite Beta. When one drug is not enough in migraine, one needs to give combination. This is a combination of amitriptyline 5 milligram with propranolol 20 milligram ER, amitriptyline 10 milligram with propranolol 40 milligram ER. So Amnurite Beta 520 ER, Amnurite Beta 1040 ER when one drug is not enough in migraine. We also launched the first pharmacological combination for neuropathic pain of 2 neuroanalgesics put together, amitriptyline and pregabalin. Pregabalin, as you know, is a BID dose. Amitriptyline is once a day dose. How do you combine this? So here pregabalin is made in a sustained release form, the TXR form, so that the pharmacokinetic profile is made once a day to match pharmacokinetic profile of amitriptyline, which is once a day. So Amnurite P for severe neuropathic pain is pharmacological to give 24 hours pain relief to your patients. We have the only one made in Japan mecobalamin injection. We import this product from Japan to offer your patients 100% mecobalamin. This is mecobalamin 500 microgram per ml injection, Neurite injection for severe neuropathic pain. We further innovated, differentiated. We launched India's first 2.5 milligram of clobazam, Adclobaz 2.5 milligram, Adclobaz 5 milligram, Adclobaz 10 milligram. You can now have a lot of flexibility and control. You can down titrate from 10, 5 to 2.5 before making it nil, or up titrate the dosage 5, 7.5, 10, 12.5, or you can give BID dosage. So innovation continues with Adclobaz. And we are very happy to inform you that very soon we'll be launching the first vitamin therapy for migraine, Brentamin. Brentamin is a combination of riboflavin 200 milligram, magnesium 200 milligram, and CoQ10. So first time of vitamin therapy for migraine. This will be a very good supportive therapy with a conventional therapy of migraine. And in those patients where conventional therapy cannot be given or because of adverse effects, they cannot be given, like pregnancy migraine or school-going children, where you think that conventional therapy need not start with, but you can give a supportive therapy like Brentamin, a vitamin therapy for migraine. And with your suggestion and guidance, we will continue to innovate, launch first time in India products. Now I have great pleasure in starting this third in the part of the webinar of headache conducted by India's leading healthcare specialist, headache specialist, Dr. Ajit Verma. This is the third in the series, and this time Dr. Ajit Verma will be taking prophylactic therapy in migraine. And to coordinate this session, I hand it over to Dr. Manjusha Patankar, MD Pharmac from KEM Hospital, Mumbai, medical advisor and regulatory expert for many companies. So over to you, Dr. Manjusha, madam. Thank you.
Well, we have with us today the eminent and renowned neurologist, Dr. Ajit Verma, who is trained in neurology from NIMHANS. He is a senior consultant neurologist at the Bansal Hospital. He has trained at the Institute of Neurology, National Hospital for Neurology and Neurosurgery, Queens, London, and Ludwig, Maximilian University, Munich, Germany. He has many research papers to his credit in both national and international journals. He has worked extensively in the arena of headache, dizziness, and stroke. Over to you, Dr. Verma.
Yeah.
Thank you.
Thank you, Dr. Manjuka, and thank you, Mr. Naik. So this is my third presentation on headache, and today I would talk about the prophylactic treatment of migraine. We would cover the following points in today's presentation: the goal of prophylactic treatment, indications, non-pharmacological treatment like change of lifestyle, management of triggers, pharmacological treatment, the comorbidity like sleep, obesity, why we fail in prophylactic treatment, and some carry-home messages. Now, the goals of the preventive treatment are to reduce the frequency of attacks. That is, if a patient is getting 10 attacks in a month, we want to bring it down to 5 attacks in a month or less. To reduce the severity of attacks, patient having very severe attacks, so in the severity from 8 by 10 in this severity score, we want to bring it down to 4 by 10. And the duration also. That is, attacks lasting for a day, we want to bring it down to few hours only. So that is our main goal of preventive therapy. But we want to reduce the disability simultaneously. We want to improve the quality of life. Patient can work and can travel, can move around with this treatment so that there are no attacks. And we also want to reduce the dose of acute migraine medications like naproxen sodium or triptans. Suppose patient has been taking 8 or 10 tablets a month, we want to bring it down to 4 tablets. So we want to achieve significant control of the frequency, severity, duration, and the medications also for acute attack of migraine. But the key indication of prophylactic treatment is usually 3 or more headache episodes a month. But also, if they are less than 3, it's a very severe attack, significantly it interferes in the activities of daily living, ADL, then also we can start a prophylactic treatment. Long duration, lasting about 12 hours or a day or so, is an indication of prophylactic treatment. Sometimes acute medications are ineffective, contraindicated. In these situations also, if you start a prophylactic treatment, patient may not need acute medications. We can also avoid the adverse effects of acute medications. Sometimes we have to see the lifestyle of a person. If it's a student appearing for a competitive exam, increasing anxiety because of headache, he's worried that he might get an attack during the exam, before the exam, may not be able to prepare. This may be an indication for starting a prophylactic treatment. And similarly, there are some special situations like pregnancy and pediatric age group where we may have to start a prophylactic treatment. Now, there are 2 aspects of prophylactic treatment: medical, drugs, and non-drug or non-pharmacological treatment, which is very effective in the management of migraine prophylaxis. And the key features of non-pharmacological treatment are sleep on time, wake up on time, sleep management, regular meal hours. Patient should avoid fasting. Some patients are benefited by taking afternoon naps. They should take afternoon naps to avoid an attack of migraine. Stress management, regular exercise, and this is very important, avoid multiple triggers. Lady patient during menses, hot weather like this, and now if she is having stress or she is going out in sunlight, there's a very high chance of triggering a migraine attack. So if there are multiple factors, it's better to avoid adding one more trigger, otherwise patient would have a migraine attack. The bottom line is moderation in all things. That is how we manage the lifestyle, which is very effective. Now we come to preventive pharmacotherapy. The important steps in the preventive pharmacotherapy are selection of the drug. And we want to have the best drug for our patient. That is what's maximizing the drug choice. Once we have selected the drug, chosen the drug, then we have very important step of initiation, then increasing the dose we call titration, and then maintaining the prophylactic treatment. What is the indication of combination of anti-migraine therapy? How long to give? And another important step is patient education. At each step, patient needs to be educated, informed about the migraine therapy. And then, of course, any supportive therapy like vitamins and minerals which we will give to our patient, which are safe and effective. Now, as far as drug selection is concerned, this is very important to understand that all drugs are equally effective of migraine. All drugs are equally effective. So, the selection of drug is not only migraine, based on migraine, but also on depression and anxiety, poor sleep hygiene. Yes? I will just do that. Now, is my voice clear? So, yes. Yeah. So it's important to understand that migraine is one aspect, but if a patient has got severe depression, anxiety, poor sleep hygiene, insomnia, sometimes the adverse effects and contraindications. Contraindications are very important. So many other factors decide to choose a drug in migraine. कर दिया मैंने. Puneet is asking. Let us see. Mandvi पूछ रहा है. बताना मुझको है. The choice of prophylactic medication. These are the 5 drugs, and as I told you, all are equally effective. But one must know that amitriptyline is a drug from tricyclic antidepressants. Sodium valproate is drug from anti-epileptic.
Yeah.
Topiramate is anti-epileptic medication. Propranolol is antihypertensive. It's very important as we go down now in the slides. Why it's important to know this. Now these are the contraindications and the common adverse effects. Now it's very important to educate our patient about the common adverse effects. Of course, if there is contraindication, we may not use these drugs. But for example, amitriptyline can make a person sleepy, and we have to educate him. Similarly, beta blockers can make a person a little dizzy. Topiramate can produce paresthesias. Sodium valproate weight gain on long term, not immediately. We have to explain and educate our patients regarding all these adverse effects. Otherwise, patient may not continue taking anti-migraine therapy. As high as 70% patients stop taking prophylactic treatment. Now, once we have selected the drug, which is based not only on migraine, but also on associated comorbidities and other factors, how to initiate? This is a very important step. Always go low. That means I begin amitriptyline as 5 milligram, never as 10 milligram, which I increase over 10 days time. That is titration period, 10 days time. You can make it even 20 days. That's between you and the patient, but always slowly titrate it. Similarly, I begin with 60 milligrams of beta blocker. We can begin with 50 also. And after 10 days time, we can titrate to 80 milligram, which is the optimal dose. Topiramate, we go very slow with topiramate because the side effects of paresthesias, which for a patient is very alarming. Which I begin with 25 milligram, and then every 15 days, I increase by 25 milligram. So the target dose is reached 15 on BD in about 45 days time. The same for these two drugs. Begin very low, increase it to the optimal dose over 10 to 15 days time. I never go beyond this dose. If you go to 25 milligram with amitriptyline, many patients will become sleepy. There are a lot of side effects. Similarly, 50 BD is an excellent dose of topiramate. If you go beyond 50 BD, you go to 75 milligram twice a day, lot of paresthesias, word finding difficulties, fatigability. So you become busy. The physicians become busy in managing the adverse effects than the effects. So you have to be very careful in the target dose of anti-migraine therapy. Now this I have tried to explain how I titrate in my patients. On day one, I begin with 25 milligrams. 15 days later, I make it 5 milligram morning and evening. I always begin with 25 milligram at bedtime. And then we go to 25 and 50. And then after 15 days, that means total 45 days time, I reach the target dose of 50 milligram twice a day of the pyramid. This helps a lot in avoiding the side effects, which patients fear a lot. And then, of course, this is my maintenance phase, which will go on for 3 to 6 months time. Now, if you start with 50 milligrams, that is a high dose, and then you titrate it rapidly to 50 mg in about 15 days time, then you are busy in managing the side effects and counseling the patient, and the patient is not very happy from you. So the rule is low and slow. Same here for amitriptyline. You see, I begin with 5 milligram on day 0, and then you see over 10 days time, I come to 10 milligrams. And if my patient is very sleepy with 5 milligrams, which is possible, then I may increase it to 20 milligrams, increase it by 12 days or 15 days also. And this is the maintenance phase. If you begin with 10 milligram, which is the full dose amitriptyline for Indian patients, then you will end up in managing these side effects only. Yeah. So begin low and go slow. I think this fact should be remembered. Now, once we have dilated the dose to the optimal minimal effective dose, 5 milligram to 10 milligram, maximum tolerance amitriptyline, we maintain it for 2 months time. And this 2 months time because drugs take time to be effective. So my drug of choice, my dose for amitriptyline to begin it is 5 milligram, then I go maximum to 10 milligram, never beyond that. What about combination therapy? Now, combination, I mean combination 2 drugs for migraine prophylaxis. I mean 1 drug plus a nutraceutical or vitamin B12 combination. I mean drug plus behavioral therapy or a prophylactic drug for migraine and non-invasive neurostimulation. This is what I mean by combination therapy. Comorbidity, patient has depression, anxiety, but must remember that amitriptyline is not a good molecule for treating depression, anxiety in migraine patient. We have to use SSRIs. We should also remember that we cannot combine any drug in migraine prophylaxis. Topiramate propranolol is not found to be effective. And last but not the least, we should not use combination to counteract the adverse effect of a drug by another medication. This is not the scientific way of managing. That is, if a patient has got weight gain because of amitriptyline, this does not mean you start giving topiramate also. You may have to reduce the dose of amitriptyline or maybe some dietary advice on exercise rather than giving these drugs combination. I found in my practice that amitriptyline is the key drug because the majority of my patients have irritability, sleep problems in their lifestyle. This combination with these 3 drugs have different mechanisms of action, and whenever there's an inadequate response to a single drug, I use the combination. Since 50% of patients have irritability and sleep disturbances, some stress, in 50% of patients, I begin with combination of amitriptyline and even any one of these drugs. This is my approach to combination medicine. Combination prophylactic treatment of migraine. Where I would use a single drug. I would use a single drug in a student who is preparing for IIT, who is more anxious than the attacks, then the severity of attacks. A young married lady who has a high risk of pregnancy, I would use a single drug. My patients who have a regular lifestyle, who can avoid triggers, who can manage their stress, and who have no comorbidity, I would use a single drug. Now, this is very important. The commonest cause of failure of prophylactic treatment is associated depression and anxiety. And this is seen 50% of the patients of migraine will have depression and anxiety. And one must remember that the propranolol and topiramate can worsen depression. And amitriptyline 10 mg, which is the maximum dose for majority of the Indian patients for migraine, would not work in depression and anxiety. So it's always good to add another drug separately for depression and anxiety. One must remember that SSRIs are not effective for managing migraine. So you have to have two groups of drugs, one for anxiety depression management, and one for migraine management. There cannot be a single drug managing both these disorders. And there are very simple questions for a busy physician in the outdoor, how to detect anxiety. And the key question is not being able to stop or control worrying, thinking about something and not able to stop, feeling nervous, which is persistence. Presence of yes to these two questions is highly suggestive of anxiety disorder. Similarly, feeling depressed, down, or hopeless, and lack of interest or pleasure in doing things. These are two key questions for detecting depression. If the patient says yes to these two questions, it is highly suggestive of the patients having depression. Depression and anxiety are the most common factor for a refractory prophylactic treatment of migraine. The next question is how long to give and when to stop. Now again, this decision is highly individualized. My protocol is I give for 6 months and then taper. And then I always advise my patient to avoid triggers, avoid risk factors like management of weight and stress, lifestyle, early to bed, early to rise, exercises, and of course, keep the SOS medicine for acute treatment handy. So along with these 4 instructions, I try to reduce the medications after 6 months of effective treatment. And we always taper and stop. We never suddenly stop prophylactic medication. So how long to give is highly individualized, but usually I give for 6 months. What about patients like a working woman, single parent, severe disabling attacks, children in 10th and 12th standard, which is a very stressful period for the family. Otherwise also stress and anxiety. 2 hours of travel for a job. Whenever these conditions are there, keeping the patient's preferences, I would like to continue the treatment. There's no harm in giving a low dose of 5 mg of amitriptyline, maybe for a few years, then to have more frequent attacks, because more frequent attacks means patient would end up in chronic daily migraine, which would be more difficult to treat. Now, whenever treatment can fail, the preventive treatment, there could be a pseudo failure of treatment. Patient not taking the medication regularly. Patient is stopped after a month because headache is episodic phenomena. Now, patients sometimes may not get headache for 15-20 days, and they may think the drug is effective and they may stop the prophylactic treatment. Lastly, they may have some unrealistic expectations. They think preventive therapy means no attacks, 0 attacks, which is not possible. It's unrealistic. Sometimes I ask my patient to count the number of acute medications they have taken with this preventive therapy. And it's not surprising that the number of acute medications taken in the last days, they go down. That means the migraine attacks have become definitely less, though the patient is not able to probably remember it. This is pseudo failure. But there could be definitely failure of therapy if patient is significantly depressed anxiety, where you have to give a separate treatment. Analgesic abuse also makes preventive therapy less effective. The dose may be inadequate, and most often it is propranolol, which is given in 40 milligrams. The right dose may be 60 milligram. An irritable, short-tempered patient with behavioral problems may be very difficult to be controlled with prophylactic treatment. Similarly, students sleeping at 2 a.m. in the morning, migraine we may not be able to control migraine even with prophylactic treatment. Lifestyle management is part and parcel of preventive therapy. Similarly, if a patient is not avoiding triggers or sometimes an incorrect diagnosis, these are the factors for failure of preventive therapy. One thing which can help our patients to monitor the treatment and the effectiveness is a migraine calendar or a headache calendar. Not only it is helpful in management of acute attacks, but also we can know why patient is getting recurrent attacks. Is it that he or she is not avoiding triggers? We can also know the number of attacks in a month which patient may not remember, but we can note from the headache diary. We can also know the compliance, whether the patient is taking regular medication or not. And sometimes, if the patient notes down the clinical features, like watering from one eye, nasal congestion, this may mean that patient is having probably trigeminal autonomic cephalalgias and not migraine. So a headache calendar is a very important tool in not only in managing migraine, acute attacks, but also in prophylactic treatment, and to know why that headache treatment is not effective. Now we can have electronic calendars these days. Patient can WhatsApp and we can know the cause and why the patient is not responsive to our prophylactic treatment. I think we should insist upon our patients to maintain a migraine calendar or headache calendar. Now, why patient education is important? It's very, very important because patients should know all about migraine. Migraine is a disease which is a neurological problem which is there. Attacks are intermittent, but disease is persistent there. So patient has to persist with the prophylactic treatment. The drug choice is not only mere migraine, but also the comorbidities, the presence of asthma, presence of depression, presence of obesity, and the patient's preferences also. It's very important to explain to our patients the adverse effects. I have very often seen that if I write amitriptyline and my patient sleeps too much, the medical shopman says to my patient that Dr. Verma has written an antidepressant because the tricyclic antidepressants are basically antidepressants, but they are also effective in migraine. Sometimes the another person may tell the patient that doctor साहब ने नशे की दवा लिख दी आपको. So it's very important to educate the patient that initially you may feel sleepy, but not over long term. Similarly, sodium valproate is being used for epilepsy. And it is not uncommon that my patients are phoned and told by the shopkeepers or others that it is for epilepsy, Dr. Verma has written this medication. And if a patient on beta blockers feels dizzy, beta blockers are basically antihypertensive medication, and the patient would definitely ring you next day, Dr. Verma, you have written me a drug for blood pressure, I don't have blood pressure. So it's very, very important to educate the patient so that the the treatment continues and they do not stop the treatment. Now, what about effective treatment? I'll come to this little later. We have to be low and slow, low dose and slowly increase it. And we must tell our patient that migraine management is a long-term investment. That is, it may take 2 to 3 months time for these drugs to be effective. And last but not the least, we must clarify all the doubts of our patient. If a patient leaves our clinic with a single or even with a single doubt, then the drugs, he may not take drugs regularly, he may stop take drugs or may change the doctor also. So patient education is the foundation of prophylactic treatment of migraine. Now, what is this effective treatment of migraine? Effective treatment of migraine does not mean 100% relief from migraine. It means 50% reduction. What is that 50%? From 10 attacks, patient may have 5 attacks per month. 10 hours duration, now the duration may be 5 hours, so we have reduced the duration. And we found the severity scale. It is 8 by 10 severity. 10 is maximum severity. So it has gone down by 50%, 4 to 5 by 10 severity scale. Not only this, the patient responds to acute treatment rapidly and there's a complete response. The number of medications taken for acute attacks go down. And therefore, the effective treatment is not 100% reduction, but 50% reduction in the migraine attacks. But one must remember, the remaining 50% is taken care by non-drug treatment, which is lifestyle and disciplined lifestyle and avoiding of the stress and adequate sleep. Now, this is a very impressive slide, which shows that patient in the beginning, when we start the treatment first month, there are about 9 attacks in a month. By 2 months, once we start the preventive therapy, the attacks become less by only by 20%, 6 attacks in a month. But you see, over 3-4 months time, it keeps going down. So prophylactic treatment or preventive treatment is really a long-term investment, and longer you continue, the more effective is the treatment. You can see that by 6 months, the attacks are only 2 per month. So this is what is, it takes time to be effective, but it is really effective and impressively effective. Of course, no good old days, I written these books about migraine, but now we have WhatsApp media, many other media through which we can educate our patient. Now, there are many other therapies in pipeline, and one of the important therapies for the future may be the calcitonin gene-related peptides, and we have now monoclonal antibodies against for the use of prevention of migraine. And there are many new drugs coming up. So prophylactic treatment of migraine has a great future all over the world. And with increasing stress, probably migraine is going to increase, but we may have more effective therapies. What about nutraceuticals? Now we have lot of nutraceuticals effective in migraine. Of course, they have their contraindications, adverse effects, but they are relatively safe if chosen correctly. And a combination of these drugs may be very helpful for students, for children, or for ladies who are young females who are prone for pregnancy. We can write these drugs and manage our patients. So if I conclude, the important carry-home messages for migraine prophylaxis. One is that we decide prophylactic therapy based on the frequency of attacks, the duration of attacks, and the severity. But there will be many other personal preferences. Both we have to use pharmacotherapy and non-pharmacological therapy. Both are effective by 50%. So you can achieve 80% effectiveness by combining drugs and non-drugs. Both are equally effective. One must remember 50% of migraine patients will have associated depression, and that should be treated independently, and usually the drug of choice, sertraline or citalopram. But remember, sertraline does not work in migraine. So you have to give a combination of antidepressants along with anti-migraine therapy. Lifestyle management, sleep management, avoiding triggers, and managing stress are very important part and parcel of management of migraine, and they are the domains of non-pharmacological therapy of migraine. The prophylactic treatment, the important not only is the drug selection of the drug, but also we must be to start low and slowly titrate. Who will win over? If you want to win over migraine, you have to be really slow, low and slow. Education is very important on all aspects about the migraine, triggers, role of stress, sleep, the adverse effects of drugs, and also we must ensure that migraine drugs are effective, but it takes time to be effective. Throughout the period of 2 months when we are on titration and maintenance of this drug, patient needs lot of support and reassurance that he would be all right. Otherwise, many of our patients may stop taking medication. So it is important to remain connected with migraine. So that's my message for today's presentation, that migraine prophylactic treatment is as effective as in 80% of the patients. The attack frequency goes down by more than 50% when combining pharmacology and non-pharmacological treatment. And comorbidities, mainly depression, anxiety, should be treated independently, not by tricyclic antidepressants. We start low and go slowly to titrate the drug to the maximum effective dose. And choosing the drug is not only migraine attacks, but also combination. So I think I must thank you all for your kind patience. If any questions, I can take now.
Yeah, we have the first question from Rajkumar from Meerut.
Yeah.
Difference between cervical headache and migraine and post-head injury headache.
Yeah. Yeah, could you repeat the question again, please?
So what is the difference between cervical headache and migraine and post-head injury headache?
Yeah. First, I would tell about the head injury headaches. Now, post-head injury headaches are a variety of types. One of them could be migraine. If the patient has a previous history of migraine, one could be migraine, but it could be a combination. It could be now a tension type headache. Post-traumatic stress disorder can also present with headaches later on after the head injury. So post-head injury headaches are a variety of headaches, but I must say that amitriptyline is a very good drug for these patients because the major problem after head injury is a post-head injury stress disorder. So amitriptyline can be given. Beta blockers can also be used in these patients. Now, cervical headache, I think it is cervicogenic headache our colleague is asking. Now, migraine patients can very much occur in the neck region, as I told in my first presentation, and they would have associated nausea, vomiting, phonophobia, and triggers and episodic headaches. And these should be managed by anti-migraine therapy.
Okay, the next question here is, what is the drug of choice for post-traumatic headache?
Yeah, as I told, the drug of choice for post-traumatic headache is amitriptyline and with beta blockers. Yes, because post-traumatic headaches is basically muscle contraction headache. They may have migrainous features also, and they have a lot of anxiety and depression. So amitriptyline, beta blockers are effective for post-traumatic headaches. Yes.
Mr. J.K. Singh from UP, Agra. Dr. J.K. Singh, why do you get pain which is an old headache pain? Very.
Yeah, I couldn't understand. Could you repeat it?
Why do you get old headache pain repeatedly?
Yeah, that's a very good question actually, because it's a disease of the brain. It looks that we get headache today because we have exposed ourselves to sunlight or we are under stress, but something is going on in the brain. We are all like hypertension and diabetes, something is going on inside. So it's very important to understand migraine as a disease of the brain. Migraine is not headache, it is more than headache. And one must know that there are a lot of issues in migraine. Migraine patients have more often dizziness. Migraine patients may have neurological features like blurred vision. Dizziness is very common. Migraine patients may have hemiparesis, difficulty in speaking. There are so many neurological manifestations of migraine. So migraine is a major neurological problem. Since it presents with headache in majority of the patients, doctors and patients think that it is headache, but it's not so. It's a brain problem which goes on in the brain and comes on surface with these triggers or change of weather and stress, etc. Yes.
Dr. Gupta from West Bengal, is nausea an essential symptom of migraine?
Yes, it is. It may not be there in all the attacks. This is very important. Therefore, we should have to have a history of recurrent attacks. Sometimes they may have nausea, sometimes they may vomit, sometimes they will have dislike for noise, sometimes dislike for light. So nausea is one of the features, but may not be there in all the attacks. Therefore, in the diagnosis of migraine, we have to have history of recurrent attacks with these features and some of them. Yes.
Dr. Narveer from Bareilly, does amitriptyline increase the risk of seizures in post-traumatic headache?
Yeah, that's a very good question. Amitriptyline reduces the threshold for seizure. That means the patient may become more likely to have seizure, but cannot trigger a seizure. Yes. But if it's required to give amitriptyline because it's a very good basic drug, and even when there's a history of seizure, I would give amitriptyline in 10 milligram, and I'm sure there won't be any possibility of having a recurrent attack. Yes.
Dr. Devendra Desale from Aurangabad, can you explain about the side effect of topiramate myopia? At what dose does it occur?
Yeah. It's a very important question. One of my patients had a topiramate-induced myopia, and normally I put a sticker on the prescription in which I write in the Hindi that if you get blurred vision because of this drug, which you may get, stop the drug immediately. Fortunately, this lady patient phoned us and she stopped the drug by herself and she improved over some time. The important point in topiramate-induced glaucoma and myopia is that we should not give pilocarpine. It should not be given. Yeah. They can all be controlled by stopping topiramate. Yeah, so you must always instruct your patient to stop topiramate as soon as they get blurred vision, and it should be written in the local language of the prescription so that you don't have any medical legal issues also.
Dr. Rao from Karimnagar, what is the role of diet in migraine?
Yeah, this is very good, important question. I have not found any role of diet in migraine, but many of my colleagues just ask my patient to stop onion, stop dhania and things like garlic. I have not found any of them have any role in migraine. Taking food on time has a greater role to play than the dietary changes in migraine. Of course, some of these fast food items, they may contain some items which can trigger migraine, but in India, the regular patients which we see, the consumption is very low. So I think patient can take the diet of his or her choice, but the food should be taken on time. That's more important. Delaying the food is a strong trigger for migraine.
Dr. Ramesh Dhamija from Agra, is there a role of deep breathing to abort an attack of migraine?
Yeah, I cannot answer this question, truly speaking. But I can say one thing, that deep breathing is a relaxing exercise. And if you are in a stressful situation where you know that these situations may trigger a migraine, probably taking a deep breath may prevent an attack of migraine. Yes, it may relax the person, may prevent attack of migraine. Deep breathing. Yes.
Dr. Chandan Kumar from Agra, according to individualized treatment of migraine, which group of patients do you think flunarizine is the drug of first choice to begin with?
Yeah, that's a good question. I use flunarizine in students and 10th, 11th class students. I use flunarizine as 5 milligram and then titrate to 10 milligram. I give it alternate days and usually for 3 to 6 months time. It's a good molecule. The only thing is that it can make a person a little sleepy, which students may not like. Some amount of fatigue it can have. It can create some fatigue in the person. Otherwise, it's a good drug. I give for 3 to 6 months time. The third important point of flunarizine is long onset of action. It is not effective in the first month. It usually starts working after 2 months. But then even when you taper and stop at 6 months, the effectiveness continues for other 3 months times, like topiramate. Both these drugs are effective even after stopping. So it's a good drug. I use it for young students, yes.
Dr. Gupta from West Bengal, when depression is the triggering factor of migraine, which should be the drug of choice as an add-on therapy?
Yeah, as I told, for associated depression, which would make the migraine prophylactic treatment refractory, we have to give a drug for depression. And the drug of choice for depression today is SSRIs. And of these, the two drugs, sertraline is better than citalopram when we are combining with tricyclic antidepressants. So sertraline and citalopram are my drug of choice for depression. I treat depression with full dosage of these two drugs and treat migraine with amitriptyline 10 milligram. I would never increase amitriptyline 25 milligram to treat both migraine and depression. It will produce more of side effects and it will not be effective for depression. So never give amitriptyline for increase the dose also for both these disorders. Treat them independently in their own merits. Yes.
Dr. Krishnan from Madurai, is there any benefit of CBT, cognitive behavioral therapy, with amitriptyline in combination?
It's very effective. If you do this cognitive behavior therapy, the principle is you educate them, you make them understand that migraine is triggered by sunlight. If you can avoid sunlight, probably you can avoid one attack of migraine, one dose of acute medication, and one attack will bring another attack. So this is what is cognitive behavior therapy. We teach them and then we ask them to change their behavior. So that is what is cognitive behavior therapy. Same holds true for sleep. If they are watching TV late in the night, they may not be able to sleep. If we educate them to avoid late nights, to avoid watching TV, they can see the same movie, same serial in the morning. This is what is cognitive behavior therapy, and it's very effective because after 6 months, when we stop anti-migraine therapy, patient has to continue with cognitive behavior therapy, managing his lifestyle, sleep, avoiding triggers, and remaining relaxed. So I think they have very long-term effectiveness, and it should be a part and parcel of treatment of migraine.
Dr. Narveer from Bareilly, since you said that migraine, 50% of migraine patients have depression and topiramate like propranolol is a risk factor for depression. So should we use it in maintenance therapy?
No, we should not. We should not. If there's definite depression in a patient of migraine, then topiramate and propranolol can worsen it. So we should not use them in the prophylactic therapy. Yes.
Dr. Chandan Kumar from Agra, are CGRP inhibitors available in India?
No, I have no idea, but they would be shortly available because now one of them is approved in USA. They are quite expensive, more than 10,000, but probably they would be available in India. Yeah. But we may not need them. You know, with this therapy, pharmacological and non-pharmacological, I have found 80% of my patients become headache free. The headache free means they may get 2 or 3 attacks which are not very severe. With very low dose of acute migraine therapy, they respond and they can live a normal life. I think in migraine, non-pharmacological treatment is not being utilized completely because it is time consuming. You have to give them, you have to educate them, you have to give some handouts, you have to teach them the methods of medication, not medication. And I think it's very effective. So migraine therapy is very effective, available today in combination with non-drug therapy. Yes.
Dr. Sanjay Kapadne from Pune, does long-term treatment with flunarizine, can it cause tremors or EPS?
Yeah. Any long-term treatment with these medications beyond 6 months, you have to monitor those long-term side effects. And flunarizine is known to produce features of Parkinson's disease, resting tremors it can produce, gain in weight it can produce. So you have to be careful beyond 6 months time. So after 6 months, after 4-5 months, we start tapering these medications and we re-emphasize patients to continue with the non-pharmacological treatment, which is maintenance of good lifestyle, avoiding triggers and stress management and regular exercise. Yes.
Dr. Gupta from West Bengal, can yogasan be useful in patients of migraine?
Yogasan will be part of non-pharmacological treatment of migraine. So it is useful, but it's 50% effective. So 50% we have to combine with drug. But for long term, yes, it would be more effective because we do not go beyond 6 months in which 50% of our patients for migraine prophylaxis. We have to stop these medicines, taper and stop. So yogasan would be helpful, yes.
Dr. Chandan Kumar from Agra, what are the Indian patients' triggers of migraine?
Yeah, very good question. The commonest trigger is fasting in Indian ladies. Second is hair wash. You know, when they wash their hair, they get a trigger for migraine. Third is, of course, menses, which cannot be avoided. Fourth is this weather, hot weather, and if you go out in sunlight, it can trigger migraine. The fifth is very high noise levels in our country. So I think hair wash, fasting, hot weather, sunlight, and noise are the key triggers for migraine. And more than fasting is delay in taking food. Indian housewives, they delay, even when they are hungry, they delay in taking the food. The delay can trigger a migraine. So I think the patient needs to be educated about migraine triggers, and he or she should also be educated to uh, to not to uh, not to take them lightly. Yes.
Thank you, Dr. Verma. This was the last question. Thank you for this wonderful and lucid presentation.
Thank you. Thank you very much, Dr. Manjusha.
Uh, Hello. Sir, thank you very much. Would you like to summarize all the three sessions that you had?
Yeah.
Diagnosis, acute, and then prophylactic. We have some time left with us, so audience may benefit from summarizing all the three sessions that we had till now.
Sure. I'll do that. Yeah. So, no. Can you hear me?
Yes, we can.
Yeah. So, it's very important to summarize all the three presentations.
Yes.
The first presentation was on the diagnosis of migraine. The key aspect of diagnosis of migraine, share the screen. Yes, full screen. Okay. Yeah. The key feature for diagnosis of migraine is recurrent headaches. Recurrent headaches associated with nausea, vomiting, phonophobia, photophobia, going on for months together. This is typical migraine. And on these features of migraine, if there are triggers, going in sunlight, delaying in taking food, this is typical for migraine diagnosis. Anything which is not fitting into this may not be migraine. Interestingly, all red flags, all severe headaches are not recurrent. So my key message would be repeated headaches, which is migraine, with nausea, vomiting, as I told. Triggered, there's a family history. So with these features, you can always make a very good clinical diagnosis, even on telephone, that this patient is having migraine. What makes you very safe in diagnosing migraine is these recurrent headaches, which is never seen in subarachnoid bleed or in meningitis. Now, second important point is recurrent headaches is also not seen in conditions like sinusitis. Sinusitis is an acute problem. It's not recurrent problem. So all those our patients who have been diagnosed recurrent sinusitis are basically recurrent migraine patients. Similarly, eye problems. Eye problems don't produce recurrent headaches with nausea, vomiting triggered by sunlight. So many of our migraine patients, they keep going to ophthalmology and they get their specs changed, but they're all migraine patients. So migraine is a big problem, varied presentation, and the key feature is repeated headaches. And the distinguishing feature from red headaches is again a repeated headaches. They usually last for a day, but sometimes they kill for 2 to 3 days time. Now, second important point in migraine is the migraine attacks are highly variable. A person may get an attack at 5 in the morning. The same person may get another attack in the afternoon. Sometimes it may last for a day, sometimes for 3 days. And sometimes a lot of nausea, sometimes with a lot of phonophobia. So physicians should understand the varied migraine phenomenology. Very, very, very varied. Therefore, when we come to selecting a drug for acute migraine, we should also know the type of attack he's getting. Interestingly, we studied 100 consecutive patients and we found that one patient may have 3 types of migraine attacks. Now, if a patient has 3 types of migraine attacks, he needs 3 different types of medications. And therefore, it's very important to have what is called as migraine toolbox. Patient should understand his migraine attacks and also should understand the medication he has to take. Since migraine is triggered in 50% of the time, it is triggered, patient should be educated to avoid migraine triggers, which looks very trivial, but we are very important, because if you can avoid a headache attack, you can avoid taking acute medication. The acute medications, we always begin with low dose, and if there's no response, we increase the dose. And as I told, we have naproxen sodium with domperidone, which is the combination which should always be used, because domperidone is a prokinetic agent. In migraine, there is gastroparesis, so drug may not be absorbed. Similarly, we use naproxen because it is rapidly absorbed. It has a long action, so it will work for 12 hours. For the whole day, it is a very effective medication. But if a patient has migraine attack in the morning, now this is a full-grown migraine attack where naproxen sodium may not work. Here, a nasal formulation will work. So migraine is another condition where you have to use more than variety of formulations. We may have to use an oral medication, we have to use a nasal medication, and we may have to use even injections like somatotron injection, which are now available, which would be coming again into the market in a very auto-injector form, where patient can inject himself with as low as 10 milligram, and it's effective. So this is all about migraine attacks, their variety. Another problem with migraine is comorbid. Migraine is very common, hypertension is very common, diabetes is very common, stress is very common. So migraine may not come all alone in a pure form to a physician. Usually it will come with some other associated problems which are to be managed. The most important problem is anxiety and depression, which cannot be diagnosed on the basis of a MRI or a CT scanning, and which can be only diagnosed by good history taking. So physicians should have assistants to help them in their busy practice not to miss depression and anxiety, because depression and anxiety makes migraine treatment ineffective. Similarly, migraine would have problems of sleep disturbance. Now, sleep is taken for granted, and insomnia is a very big factor for refractory migraines, and therefore sleep should be assessed and managed properly. Cognitive behavior therapy may help here a lot. Now we come to today's presentation of prophylactic treatment. We have 5 drugs, all are equally effective. So it becomes very difficult to choose which drug, because now it is not the effectiveness, it is the associated comorbidities which are important, like obesity, where I would like to use topiramate. But since patient is anxious, little bit of anxiety, irritability, sleep disturbance, I may use amitriptyline. In a female patient of 16 years with mood fluctuations, I may use sodium valproate. So depending on the other factors, factors, I choose a drug and I educate them, because patient has to be with us for 2 to 3 months time for drugs to be effective. And it's very difficult to keep the patient waiting for drugs to be effective. So we have to educate them a lot, and we have to give them acute therapy simultaneously. And once after 6 months, I always ask my patient never to stop suddenly. Quite often they stop suddenly. And in that case, migraine may recur. So we ask our patients to taper, we explain them how to taper these drugs. But once we have tapered the drug, patient is being managed by non-pharmacological treatment, because they are safe, effective, and they don't cost much. But patient cannot take drugs for remaining for decades or years together. But there is a subclass of patients, like a single mother bringing up 2 children, which is very stressful, and she is working also. In these conditions, where I would like to continue prophylactic treatment in lowest effective dose for as long as the patient can take, if there are no serious adverse effects. So this is how I manage my migraine patients, and we explain all the aspects of migraine. We clarify all their doubts so that they are reassured that they are being managed in the best possible way. I think it's like this is what I can summarize my 3 presentations. Yes.
Sir, thank you so much for summarizing these 3 parts of the presentation. You have taken us right from diagnosis of migraine to differential diagnosis of migraine, tension type of headache and other headaches, then to acute treatment, and then today prophylactic treatment. This was a wonderful session that we had with you. Very, very practical, as Dr. Manjusha said the other day. I am sure our audience must have found it very, very interesting and enlightening. I would like to thank you for being our speaker for all these 3 sessions. Thank you so much. And audience has heard India's leading headache specialist by this webinar, explaining everything, all aspects about migraine. So thank you very much, sir. On behalf of Health and You,
Thank you.
we'd like to thank you for your efforts. It was wonderful to have you for all these 3 sessions of migraine. Thank you, Manjusha, for coordinating these sessions very well and taking the questions from the audience. And finally, the audience for taking off your time from your busy schedule to join us for these webinars. I am sure you must have found these webinars on migraine very, very interesting, enlightening, and very practical, so that you can take out few top points and go back to your practice and implement them in your practice to make people life better. Please continue to prescribe Health and You products, the innovative first time in India products. Many of them are for migraine, and would like to thank you for also taking care of COVID-19 patients in this pandemic. On behalf of Health and You, this is Deepak Naik signing you off. Thank you very much for joining. Have a very good day ahead. Thank you once again, sir, for being our speaker. Thanks a lot. Pleasure to have you with us. Thank you, Dr. Manjusha.
Thank you.
Thank you, audience. Have a good day.